Welcome back, everyone. I'm Dr. Ashwin Vasan, as Harold so kindly introduced me. It's really my honor to be here today to moderate this incredible panel. You just heard from three of the leading researchers into suicide risk, suicide detection, and in developing solutions to mitigating the impact of suicide. This is a difficult topic and a very human one. My life has been impacted by suicide. My uncle took his life, died by suicide when I was 10 years old, and such was the stigma around it that I didn't even learn about it, the cause of death, until I was in my 30s. And so when we're talking about this, we cannot fail to see the human impact, and I know that's what's driven these incredible researchers into this field. And I feel very lucky to be here with this panel because we're applying the best science, the best multimodal techniques, and some of the most innovative research in the nation to really driving down on the risks and the causes and the solutions. As a former health commissioner, there's nothing more than I wanted than to see a package of solutions that I could then use policy to scale. And I know we're on the right road in large measure because of the work of these fantastic researchers today. And frankly, as a lapsed academic, it's nice to be on a panel with a bunch of people much, much smarter than I am. And so you've already met Drs. Nock, Dr. Cha, and Dr. Gratch. And I'd love for our other panelists who joined us to just quickly introduce yourself and tell us in one or two lines what your work is in the space of suicidology.
Wonderful. Hi, everyone. My name is Jocelyn Meza. I am a licensed clinical psychologist and professor in the psychiatry department at UCLA. And I study structural drivers of suicide as well as social cultural risk and protective factors for suicide.
I'm Dr. Kathleen Merikangas. I'm a senior investigator at the National Institute of Mental Health, where prevention and understanding of suicide is part of our major mission. My work has involved studying how diseases run in families, particularly mood disorders, and how they're related to suicide, and understanding the dynamics of mood and how it's related to sleep, physical activity, and pain, and how that may lead to suicide attempts and suicide in the general population.
Hello, I'm Dr. Daniel Lowe. I'm a research scientist here at Child Mind Institute, and I did a postdoc with Matt Nock, which was wonderful. And I study how we can detect suicide risk from speech and language patterns. So I use AI, large language models, machine learning to do this, to detect patterns in text and the audio of speech recordings. And then I'm trying to figure out what's the risk of different exposures like social media or AI chatbots in mental health, and how we can use novel interventions or historic interventions like psychedelics and meditation to improve mental health.
I think the role of this panel is in many ways to try to make sense of what we're seeing broadly in the space of suicide risk and suicide risk mitigation and solutions, so that a whole range of stakeholders, whether you're a parent, whether you're a teacher, whether you're a young person yourself, whether you're whether you're engaged with young people in some fashion, that you have a better understanding of what's out there, because we are awash in information. I think we heard a little bit about the vast amounts of data we're collecting every day through routine surveillance, through wearables like this. And so I wanted to start to pose a question to the entire panel, and maybe we'll start with you, Matt. We are awash in all of these data, and these data are being collected routinely. Many people are opting into more monitoring of their sleep patterns, of their movement patterns. How do you start to make sense of all of this, and how can ordinary people start to make sense of it?
Yeah. Great questions, and I want to come back to something you said earlier, if I can, about being ordinary people ourselves. We, as researchers, focus on this topic, present often in a cold scientific way, but I just want to highlight how important the problem, how human the problem is. Statistically, all of us have been affected by suicide in some way, given the numbers. myself included. So have lost a very close, one of my best friends to suicide, and I've had suicidal family members and so on. And I think a lot of us get into this field, in this area, for the reason of wanting to help others, and it doesn't immune us from being affected by it personally and for those around us. So thanks for raising that and for the opportunity to say a little bit about it myself. I think it's a really exciting time, given that we are awash in data, and as I mentioned briefly during my remarks, a lot of us parents especially wring our hands about how digital the environment is now for kids, and I agree. The kids are often overly immersed in their iPads and their iPhones and so on, and all of us are tracking our steps and running and breathing in ways that we haven't been before. There's a lot of mess. There's a lot of noise in a lot of data being captured that's not so useful. How we approach it is we try and use science and be really systematic and work through the data and see which of these signals, which of these pieces of data are helpful in helping us understand our mental health and as they are our physical health, and which are not. And how can we take the science that we're doing, for instance, having people at risk for suicide wear wrist-worn monitors, and we measure sleep, and we measure daytime activity, and we measure call and text, how much you're calling and texting others. And some of this is helpful. The extent to which a person calls and receives calls from others is associated with a decrease in suicidal thinking. Makes sense. The more connected you are with someone, the less you're thinking about suicide. Some of the data we're collecting just aren't useful at all in terms of prediction. There's a lot of apps. There's an increasing number of apps in the world that are mental health apps that are really well intended, and we know that most of them are not evaluated, and many that are evaluated and found not to be helpful. And I think the only way forward is, or the best way forward is science, is using systematic observation, experimentation, figuring out what works, what doesn't, and let's get the things that work in the hands of our children and families so they can make use of them and live healthier lives.
I mean, it's really remarkable, the career you've had in particular, because really over the last 2 decades or so, maybe more, you've shined a light on an area that was so hidden in darkness. And as an epidemiologist, it's rare that we often get accused of admiring the problem. But when you don't know much about the problem, and there's so much lack of understanding, you almost have to look everywhere. And now, as you rightfully point out, there's data everywhere. And so one of the takeaways from the presentations earlier is that suicide is a complex issue. And so when you have a complex issue, multifactorial risks, and you have a complexity of data around you, how do you start to make sense? There's no smoking gun. There may not be any one smoking gun. But how do you start to think about composites and putting multiple data sources together, multiple data points together? Anyone can jump in.
I would love to chime in on that conversation, because when we think about data, we tend to think about numbers. And part of my research really focuses on how do we contextualize this phenomena. And one of the things that I had to do is how can I step back and listen to people with lived experience? Let them guide what I'm doing. So one of my favorite projects that I recently completed is doing qualitative interviews with youth that have been involved in the juvenile legal system and that had a suicidal attempt or that have experienced suicidal thoughts, and asking them to tell me your story. Start where you want to start. Tell me what were some of the things in your environment that impacted your risk for mental health. And one of the things that struck me in listening to their story was that a lot of the things impacting their suicide or their mental health were structural issues that we rarely discuss when we're talking about suicide. So that was just something really interesting that I wanted to bring up, is that there's different types of data. How do we bring in the type of work that we're doing together?
No, an excellent point, and I want to bring that back in a minute as we start to talk about who gets overlooked in the data. But let's bring it just back to the technology just for a moment, because we're awash in so much technology and more surveillance, and we haven't even gotten to large language models and the role, all the things that folks listening are reading in the news and engaging with. The truth is, it's a reality. It's not going anywhere. I like to say I'm no tech optimist, but I'm an inevitablist. It's here, and so we have to make sense of it and start to figure out ways to use it responsibly and to protect people and put in safeguards. And so how do you start to think about that in your own work? How's the NIMH thinking about that?
Well, I think one of the big gaps, I'm an epidemiologist as well, and I think we neglect the epidemiologic data worldwide on differences in suicide. If you look at the rates, there are dramatic differences across the world. And I think that's really an important clue, because it's not all related to the availability of mobile phones and so forth. The cultural factors are overwhelming, either both within the country as well as across the world. So I think there's a lot of data that was not collected at the individual level, but I think there's a gap between that and what we actually do in clinical settings and the research that we do. And I think it's really important to bring it back to that level to look at differences and then try to identify what are the mechanisms, what are the explanations for these differences in terms of elderly versus young people, big differences there across the world. So I think that's really important.
What it seems to be clear is that there's certainly no one-size-fits-all solution, right?
No,
and,
right.
and whether that's cultural differences, age differences, I mean, the sort of, it's almost a micro-targeting kind of approach at a population level and a subpopulation level.
Yeah.
But when we start, what folks are really, I think, dying for is to understand the trends.
Yes.
And so I'd love to turn it to you, Christine. Like you start to, your work in broad strokes is looking at protective factors in some ways. And so how do you start to, when it feels like surveillance and technology and data is everywhere and hard to make sense of, how do you start to pull out these protective factors, which ultimately we all want to build solutions around so that we can build the firewalls up for our young people in particular. So how do you think about that?
Well, first, I appreciate that term of protective factors. That's a lot of how I think about the work that I've been doing in this area, future life-oriented thoughts and feelings that that teens experience. I think this, while it is the case that there's a lot of technology around us, I think this question, we're past that point of saying, is technology good and bad, and really trying to lean into what might be adaptive ways in which technology could, for instance, can it help foster in-person connections with others? Can it help foster a sense of connectedness with oneself? And how can we leverage some of the best parts of technology in a thoughtful way? And also bringing in, I loved your points, Jocelyn, just around drawing the wisdom not only from the numbers, not only from the past literature, but also from those with lived experience, and then other stakeholders, whether that's parents, guardians, teachers, and so on and so forth.
Yeah, I was going to kick it to you and Ilana to talk a little bit more about the precision with which you do detection and using advanced tools to enhance that precision. Tell us a little more.
Thank you. I think there's one line of research where we could assume someone will enter the clinical care and will want to integrate data from ecological momentary assessments, from rating scales, from speech, from language, from image kind of recognition. But then there's another line of research where we only have a kind of a glimpse into someone's mental health, maybe because they're posting on social media, and that's our only opportunity to intervene. And so some of the work they've been mentioning is that sometimes crises happen within a few hours, so we can't wait for them to kind of be seeing a clinician, and we need to kind of leverage everything we can, maybe from that one social media post, from that one contact to a friend. So some of the work we do is not only measure explicit suicide risk factors in text, but many other risk factors that have been known to indicate risk, like perfectionism or discrimination, or symptoms of borderline personality disorder. All the things people might be mentioning when they're not willing or not aware of their suicidal ideation explicitly. So it's super important to be able to capture kind of those cases, and it's kind of more of a low-hanging fruit. If we could get that person to call a hotline or reach out to a caregiver or a friend, we might make a huge impact, right? So we're still not there with that even, right?
So does that lack of maturity in the response, maybe for lack of a better description, we're working on it, of course, on that response, both the response time and the sort of specificity of those responses. Does that make you any less able to kind of interpret these data that you're collecting? I mean, I was really intrigued with the sort of the facial expressions and the extremely granular work you're doing to try to unpack something that is so hidden away and so mercurial. I mean, and can shift. I was really struck by, I think it was, I don't remember which presentation it was, but you said that, that a young person who has reported suicidal thoughts will then deny ever having them a week later. That just speaks to how much language actually can sometimes be in a barrier to. So how do you start to think about these nonverbal cues and the sort of very specific detection methods that we're trying to unpack, and how do you put that into context with all these other epidemiological and structural and population data?
Yeah, I think we need people thinking about it at all levels and in all sort of like fields to come together more like we're doing now. It's really nice. The way that I tend to think about that research, the nonverbal piece and the facial expressions, for me is less that I feel we're in a place to say like this, facial expression means X, or like now we can put a camera in the room and detect risk. Personally, I don't feel there. For me, it's much more like then thinking as a clinician, what are the sources of data that I need to think about or attend to that I might otherwise be neglecting? Like, it's not enough to just ask a question once and move on necessarily, or to just pay attention to what's happening in the patient or participant. Like, I need to pay attention also to what's happening in me or in the room, or whatever else. The structural factors, everything. It's just like expanding the lens or something.
Well, I think about this in a therapeutic context, which is an extraordinarily private, dyadic relationship, right? You're in a room, the expectation is complete privacy, no other data collection other than what is being observed and heard by the clinician. Do you see a world in which, in the future, patients could consent to other observed tools in the room? And I mean, they're being observed. We are all being observed in many ways, and we opt right now, and we opt into those observations.
Yeah.
Sometimes we're allowed to opt out. Do you see a world in which there's some of this optionality inside the clinical environment?
100%. I think it's going to become increasingly normalized. A lot of the monitoring work, all the work we do with people's consent, of course. Younger people are much more, children, adolescents, much more like, they're more used to digital interaction and are more familiar with a lot of the data capture approaches that we're using. And parents, and in my experience, have really liked a lot of the work. If you have a kid and they're thinking about suicide, they're at high risk, and we're monitoring them over time and providing information back to parents about when risk is high and how they can help intervene. Parents like that, and they often say at the end of our studies, "Can we keep going? Can we keep doing this?" And if the child is into it, not okay with it, and the parents are interested, then I see a really strong future for this. And I think again, this is a way where we can use these tools. The digital tools are just like any other. A sharp object can be used as a scalpel or a murder weapon. The digital tools can be used for good or for evil. How can we use them to help improve mental health rather than allow them to harm the mental health of our kids?
I mean, certainly medicine is moving in this direction with digital scribes and upskilling, in consultation support, and we haven't yet quite seen that in mental health, but it strikes me that it would move in that direction as well. And I think your work in particular is so targeted at the things left unsaid. I mean, most of the technologies that we're focused on are ambient listening and digital scribing and using that as a predictive tool to make recommendations even. But you're talking about the unsaid stuff, and that I find extremely intriguing. Maybe a little troubling, but also intriguing. And I think it's important to have a dialogue about that in open. And so. Let's get back to this question of equity and disparities. In New York City, suicide is the 6th leading cause of death for Asian Americans. It's the leading cause of premature death in the city, which means, as you described, it takes the most life years off prematurely for deaths below age 65. When we created our Healthy NYC agenda, the plan for the city, law, frankly, we struggled to create a suicide target. And the team wrestled with it. But in part, it was because we didn't have clear sets of interventions that we could scale through policy. So let's take youth mental health and youth suicide risk. I'm a parent of three children. My children already are not spending very much time with me. And they're still young. So most of the time they're in school, right? So how do you start to think about the myriad stakeholders that are actually spending more time with your child? And how much work are you doing with schools in particular? I'll bring that back to the equity question in a minute. Has anyone's work kind of focused on teachers and the school environments, please?
We haven't yet. I mean, there is work on suicide focused on the schools, and there are programs that the Signs of Suicide program have shown really positive effects for helping middle school students, high school students, teachers understand suicide better. I mean, I'm struck by the fact that we are okay as a society doing, to varying extent, doing school shooting drills, but suicide prevention can't be talked about because there's a concern that it's going to harm our kids. Kids are much more likely to die by suicide than they are by shooting. All of us are. This is true globally. Suicide takes more lives than around the globe each year than all wars, all genocide, all interpersonal violence combined. So we're each more likely to die by our own hand than we are by someone else's. This is true in the US, it's true around the world. We have to do something about it. So we have to talk with teachers, we have to talk with parents, we have to talk with people in the community, we have to talk with coaches. And there's evidence that these programs don't do harm, and they lead to increasing evidence that they can lead to positive outcomes. So there are people doing this work, and I think we need more of it. And the more we do it, the more it's going to fight against stigma. I would also mention, last thing, and then I'll be quiet for just a moment, we need more funding in this area. If you look at leading causes of death, suicide is always in the top 10, hovering around the top 10. And if you look at how much research funding by the federal government goes to the leading cause of death, there's a big drop for suicide. It's a third of the leading causes of death around it. I think this is because of the stigma around suicide. We need to do more. We need to treat it like other causes of death, and we need to treat it proportional to how big of a problem it is, and the fact that it takes so many lives of young people. And there's so many years of life lost, and we're not doing nearly enough to try and address this problem. So we do need teachers, we need parents, we need communities, we need whatever help we can get to try and turn the tide.
At the college level, it's quite different. And what happens at the college level, if a student comes in and has made a suicide attempt, they get expelled from school. So instead of treating people and welcoming them and helping them to adapt with whatever the problem is, they end up leaving school because suicide is seen as something that is not the responsibility of the school. And so the programs there are very difficult to administer as long as they have those legal sanctions with students being expelled. So I think that's a really important issue that we need to address as a society, because we should welcome students coming when they're in despair and to support them rather than having them lose their educational opportunities.
And I think at the college level, one of the main challenges is that there isn't a standardized way on how can we support students that are struggling. And in some schools, it is criminalized, right? If a student reports that they're having thoughts of suicide, what happens is that the campus PD will come handcuff them and walk them over to the emergency department, which can lead to a lot of shame. And the students that are witnessing this, that may themselves be struggling, may say, you know what, I don't want that to be me. So I'm not gonna talk about it. And I think that's where the JED Foundation is doing a lot of work on how can we create systems that support students and not criminalize their mental health in a structured way.
I mean, I think the theme that we're all describing is how much we work to push this into the shadows, to keep it in the shadows. And your work is trying to unearth quickly both understanding and solutions. You all described a range of stakeholders, whether it's fellow students and peers, academic institutions, teachers in school. How do you think about your work in terms of rapid translation, getting information into the hands of the people who can make a difference? You've been a part of developing a number of tools, scoring systems. How do you all think about your work in the digital space and in the clinical space and in the epidemiological space in terms of who's the audience you're thinking about when you're designing your research questions, when you're developing your tools?
Yeah, I can start. We focus on clinical settings right now. And it's not to say, so half of people who die by suicide were seen in a clinical setting in the month before they die. Half weren't, so we should focus outside of healthcare settings as well. But from my view, if half of people are coming in front of us and we're missing them and we're not doing enough, that for me is where I want to start. And we think increasingly about implementation. We don't want to do science for science sake, and while people are continuing to die, while our children are continuing to take their own lives. So we're constantly, and NIMH has been wonderful in this regard, creating a number of practice-focused suicide prevention research centers around the country, where there's clinicians, frontline clinicians working side by side with researchers, working side by side with people with lived experience, figuring out how can we change the system and test those changes to see if we can get better at identifying who's at risk and decreasing risk. So,
but can I push you all on this question? Because I think about this a lot in my own clinical practice. You know, I see a patient for maximum 30 minutes, and then they go on to have 23 hours and 30 minutes of their life that day. And part of my job in primary care is to try to understand those 23 hours and 30 minutes better. And now I have a lot of data, a lot of tools to do that. I also have to talk to a lot of other people outside of the clinical setting. So how do you sort of apportion that time in terms of your work when you actually have such little observed time with your patients? How do you think about the weighting of where you can actually gather the most data?
Very, very carefully. We've gone through the phase of saying primary care doctor, every primary care doc at every visit should assess this. And I was at a talk in a primary care doc, and I said, if we did every screen that everyone wanted us to do, each visit would be 6 hours long. Because of substance use and alcohol use, it's all important, but we just can't do it. So we can't put it all on primary care docs. And this is why I think we should all work together on this, and scientists should work with the folks on the front line to figure out, well, what can be done? And one strategy that we're using, and I'm curious to hear from others about theirs, is using a really efficient digital approach where we scan. We have so much in the medical record. It's no longer, you go see your primary care doc, they don't write things down and stuff it in a file folder, put it in a filing cabinet anymore. Now it's all digital. They're all numbers. We can analyze them and find patients at risk, but we're not going to put it on the primary care doc. We then have a team of people who reach out to those folks. So we find people at risk and find people at really high risk, and then apportion resource to that person and test out different ways of turning a lever where it's going to make sense and where it's going to fit into the healthcare system. Healthcare systems developed by tradition, by what we do, not by what's most effective always. So we need to do the science and get it implemented to cause change.
And I think there's this statistic that there's like 17 years between something being in science and into practice. That's 17 years that we don't have for this problem. And one of the ways in which we can reduce that timeline is doing community-based participatory research. How can we meet the community where they're at and bring science to them and kind of build this equitable partnership? So one of the things that we have done in my lab is we've brought in these stakeholders that work with populations that are at increased risk for suicide. So these are probation officers, judges, public defenders, district attorneys, and working with them to design studies from beginning to end. It's not just, can I ask you a few questions? Is, can we really build a partnership? What are some of the questions that we need to be asking? Who do we need to talk to? And how can we work together to come up with a solution together? So I think community-based work is so important in bringing our findings into community solutions.
Yeah, and there's also a way research can quickly change society, which is through policy or lawsuits. Policymakers are waiting for that evidence to either push a law or, companies are also waiting for some evidence. And some of these bigger companies can change the lever on some of their algorithms and affect hundreds of millions of people. And that can come from, single papers and scientific articles, right?
I mean, certainly from the policymaker's point of view, we, on this issue of suicide and suicide risk, we've always been desperate for something that we can package that we know will have an attributable impact that will make a population level difference. What I'm learning and what we see is that there's so many things that can make a difference.
Yeah.
And so, weighting in priority ends up being the public policy choice. But in the life of that person, you have to take all of that complexity into view. So how do you think about that in your practice? How many of you are practicing today? Yeah, so all of you, almost all of you. And how do you think about that in the life of your work? I'm a lapsed researcher. Some of my best research, though, has come from patient experiences, of course. But there's such a complexity in the life of any one patient. But then there's obviously things that you want to structure in public policy that can help as many patients as possible. How do you think about that in the kinds of research questions that you're asking and setting up the kind of grants that you're writing?
I think from a precision medicine perspective, I think keeping in mind that suicidal thoughts and behaviors are not a monolith, and that there can be in many cases a trajectory towards something like a suicide death, and trying to figure out, for instance, among these many different intervention approaches or assessments, what is the actual outcome that we're trying to either predict or prevent. It might be a different type of intervention to reduce the severity of suicidal thoughts compared to preventing that transition from suicidal thoughts to attempt, or stopping a person from attempting and managing access to lethal means. So I think first and foremost, really thinking what is it that we're trying to, getting very precise in what is it that we're trying to solve.
Shall I jump in and bring this point to one that Kathleen and Jocelyn made earlier? I'm thinking about the work of our late colleague, Jerry Kagan, who said a lot of brilliant things, and one of them was psychology, psychiatry have been a little bit lost. And we haven't done what every other area of science has done, and so we haven't made the same advances, and we haven't found the problem we're interested in and just focus on it and study its properties really, really well. Instead, we come up with theories about why we think people kill themselves, and we design brain imaging experiments and lab-based experiments and try and simulate what we think might be happening. We haven't observed and talked with suicidal people and looked at the epidemiological research to understand when are people at risk. Doing qualitative interviews with suicidal people to say, why do you want to kill yourself? Why did you try and kill yourself? And when that work is done, what we learn is about 90+% of people who try and kill themselves and survive and do interviews say, I wanted to kill myself not because I wanted to be dead, but I wanted to escape seemingly intolerable pain. And I think that for me is a North Star. And all of the noise that we're thinking about, that's what people are most often, not always, but most often trying to do. What causes that is going to be variable for different people. But can we understand who is experiencing pain and why are they trying to end their life because of the pain, and work backwards from there in terms of thinking about predictors and who we're working with and what we're focusing on. But for me, that's a big way to try and cut through the noise. And it's a way to humanize the process and remind ourselves, this is the reason, or talk with people about what is the reason. There's going to be variable reasons, but what is the reason? And let's use that to organize our thinking.
Well, one of the aspects of pain, there's physical pain, and then there's psychic pain. If you talk to someone with bipolar disorder, for example, the pain is so intense, it's worse than any physical pain they could suffer. So what a lot of us have been doing is looking at other indicators of difficulty, and we found that sleep is one of the most important characteristics to measure within individuals over time. And you're talking about all these devices. There's thousands of them. It turns out the science of difficulty sleeping is really not there yet. A lot of commercial work, but there's gaps between that and the real research. But most people who make suicide attempts, it occurs in the middle of the night and early morning, after a night of having difficulty sleeping. So, I mean, that's a really important clue, because we see the world a little differently when we're ruminating during the night and when we get up. So I think those kind of diurnal patterns and seasonal patterns are also very important. We talked earlier today about seasonal patterns of suicide, which peak surprisingly in the spring and fall and not in the doldrums of winter. Most people will believe they occur in winter, but actually the aggregate data across the world shows a spring peak. And some people are suggesting it has to do with a shift in daylight savings and so forth that really shifts people's rhythms. But I do think, to get back to your question as primary care physician or psychiatrist, any field, understanding how people are sleeping, and we can do that now in real time. We can measure their sleep with, sleep, these actigraphy devices, and most of the sleep research is now being done in the community at home. So I think that would be one of the tools one could use across medicine and psychiatry.
Well, this is a great segue because there is obviously a massive explosion in interest in wellness and longevity, and we can debate whether that's healthy or not healthy or good net for society. But perhaps one of the positives is that people are talking about and paying more attention to things like exercise and diet and sleep. So as you're thinking about the future of or the present and the future of your research, how do you capitalize on these movements and start to link them back, both as protective factors, but also as, in their absence, as risk factors? And has that work been done? And where does it sit in the sort of range of your work?
Yeah, the work's been done. I mean, the effects of aerobic exercise on mood, on depression. We have some work on aerobic exercise and self-injury, non-suicidal self-injury, cutting and burning, and it just drops it right out. And it's free. It's not used nearly enough. There's not a lot of money to be, this is a cynical view, but there's not a lot of money to be made on exercise and diet. And so people they're not prescribed as much. And there's been recent discussion about, well, should they be? Is it unethical for clinicians not to be prescribing exercise given the positive effects? So I think there's definitely a lot of intervention in there, effective intervention that could be done and should be built into things. And there's also, I don't know if I call it a branding issue, but people don't like to talk about suicide. They don't like to be asked about suicide. People like to talk to each other about suicide. We don't mind talking about wellness and health and doing better. So I think for multiple reasons, it's a great question, it's a great point. We need to be doing more to prescribe these things, build them into treatment, and focus on, as Christine was talking a little bit about earlier, not just death and dying, but thinking about a positive future and how to improve health and develop a life worth living, rather than only focusing on finding people at risk and preventing them from killing themselves. What next? What else? So it's an important piece of the puzzle from my view.
Yeah, and I think Jocelyn was pointing to contextual factors. So we can try to try to do fancy machine learning and AI to figure out how much risk, if someone mentions depression versus anxiety versus shame, how much does that indicate risk? Yeah. But one could ask, well, what's causing those risk factors? And sometimes it's lack of community, and then there's all the protective factors that decrease those. So maybe for some people it's spirituality or exercise or meditation. And so we also need to focus on those things, I think. Yeah.
I love that. My favorite question that Christine asked me yesterday during our dinner was, what is the protective factor that you're most excited about? And I really had to think about that because, we study sense of belonging as a protective factor. And I remember my answer was civic engagement. And one of the really interesting things that we're doing in our lab is understanding how adolescents and college students that engage in civic engagement, addressing social issues that are impacting them, could be really protective for their mental health. The issue here is that civic engagement is protective in certain contexts, not in every context, right? So really trying to find that nuance of when is a protective factor and for whom, under what circumstances.
So let's build on this because I do, whenever there's, let's call it relatively nascent areas of research, right? I don't know how old the field of suicidology is, but its explosion has been in keeping with the explosion in interest in research and funding for mental health. One of the areas we tend to avoid is talking about structural, systemic, economic, anything factors that can either be risks or protective. And in part because I think, all of us trained clinically, none of us really started our careers trying to understand, public policy and the swath of it. I've gone in that direction over many years, in part out of frustration of seeing someone else making decisions that are affecting my ability to do what's best for the community or the person or the program that I'm working in. Where does that kind of systemic analysis and structural and economic and especially at a time, economic analysis, especially at a time when it's clear affordability is top of mind for all Americans, where does that fit in terms of material need, the intersection of material need and suicide risk? What do we know? And is it being paid enough attention to in the range of research? It's like the opposite of the microfacial targeting, I would say.
Yeah.
Yeah, there are huge demographic patterns in suicide risk. We see them by gender, by race, ethnicity, by age, by geographic region. We don't really understand them. We know that social determinants of health, as they're called, a lot of these factors do impact people's health, and they do help us predict risk of suicide. Females, people identified as females, think about suicide and make suicide attempts much more than do males. Males die by suicide 4 times as often. It's true at virtually every country around the world. The lowest suicide risk in the US is around this region. It's New York, New Jersey. I'm from New Jersey. I think it's high quality of life. People often push back on that. The highest risks in the US are north and south of Las Vegas. People call it the suicide belt. Why? We don't know. Population density, we think, has something to do with it. Where there's people around, where you feel connected, where you belong, there's lower suicide risk. There's less access to care out west. People are socially distanced. They don't have good access to good treatment. They have more likely to have firearms. This, we think, is a recipe for higher risk. So there are big structural things and big sociodemographic factors that play into risk. Your question was something along the lines of how does this play into things? I think these are big pieces of the puzzle, and we can't, in any one intervention, address all of them. We need to be thinking at a structural level, at a sort of meso level, at a micro level, and these things need to start working together.
Are you accounting for this in your cohort designs and like where you do your research? You know, if you do all your research in the Northeast, it's obviously systemically biased. How do you think about this when you're doing multi-site studies, or where you want to work?
Yeah, we work with epidemiologists like Kathleen. We work with collaborators around the world and look at differences in countries and cultures around the world. But that's not going to answer the micro question. So we do other studies locally and then try and replicate those in other places around the world to see, is this a local biased finding, or is it something more general about suicide?
I think this is like essential insight for the audience, because I don't think most people understand how we ask these questions and design trials, and then we publish a result and we think, oh, that has to be generalizable. So let's extend that analogy to race, ethnicity, and so forth. You know, I come from an API community. As I mentioned, it has a very high rate of suicide and premature death due to death by suicide, and yet has some things that might be traditionally thought of as protective factors: higher rate of living in intergenerational families, and stronger social networks, social ties, intergenerational social ties, less economic insecurity, actually longer life expectancy overall, but higher rates of suicide. How do we capture those social and cultural factors and specificities? Latino populations as well have higher rates of suicide than, at least in New York City, than whites. So how do we think about pulling these data out, other than passively through demographic collection? How do we think about it in the way in which we tailor interventions, and the way in which we sort of design trials for specific, often overlooked populations? Anyone can jump in.
Yeah, one thing is that when you train machine learning models, the model's going to try to predict some outcome, let's say suicidal ideation or suicide attempt, from patterns in the participants' data. And so it's heavily influenced perhaps by demographics, socioeconomic factors. Those will change once the model is deployed from, you go from a research setting in one clinic and then you deploy it to the general population. That association might break down, right? So that's super important to include more representative participants and more participants from different demographics in your training data, basically, and test it on different demographics.
Yeah, our data really needs to be able to contextualize the problem, right? So some things that I always collect in my data sets is housing and food security. Like, do they have access to basic human rights, like affordable housing and food? right? Collecting data on their race, ethnicity, right? Which I think has become an issue more recently, but how do we collect data on that? Systems involvement, have they been impacted by the child welfare or juvenile legal system? And I think one of the most important contextual factors that gets overlooked in this research is access to mental health care. Because we know that's like a big issue. We don't have enough of a workforce to be able to provide services or access to all youth. So if we can contextualize in our data those structural level factors, I think will be really helpful.
And if you look at the data nationally in the US, 90% of suicides are white people. 80% are men. White men are very high risk, and the numbers go off the chart after age 65. That doesn't mean this is the only group at risk. Of course, indigenous groups in the US, higher risk. So risk varies by race, ethnicity, and gender generally. I think an important thing to keep in mind is a lot of the risk factors we see are the same across groups. Mental disorders, not just depression, bipolar disorder. 20% of people with bipolar disorder die by suicide across races, ethnicities. The piling up of mental disorders. If you have 2 or 3 or 4 different mental disorders, this really increases your risk across genders, race, ethnicity, countries, and so on. But there are different kinds of risk factors that emerge for women versus men, for people who are identified as being white versus Latino versus black, and so there's some generalities and there's some more specific findings, and we're trying to piece together what are the big universal things that put people at risk, what are the things that we can use to get more precise in our models. Well, I'm say not just we should focus on suicide on white people, but a lot of us are at risk. Suicide knows no bounds in terms of who's going to be affected by it. So I'll follow up on that. So what do we know, for the audience in particular, what do we know about the intersection of substance use disorder? What kinds of substances? How often is that involved? And for which population? I mean, you mentioned a population that's already at elevated risk for substance use disorder. Yeah. So how do you think about, what do we know and what can we tell the audience?
Well, it's different for different substances, but what you tend to see in families of people with bipolar disorder is substance abuse is a consequence of that disorder, as well as anxiety disorders. So when you have those two ingredients together, the risk quadruples. So it's people and it's not just a dependence on the substances, it's the use, acute use of substances that may diminish the inhibition. And it's very different for different agents. We have alcohol, across the society, but now we're dealing with fentanyl, we're dealing with accidental overdoses. So the drug use and abuse field has devoted a lot of effort to understanding how drug use and patterns are related to suicide, because it turns out to be really one of the most potent factors in deaths. Which could be accidental or could be volitional. Yeah,
people often use alcohol and drugs, coming back to escape, as a means of tamping down negative affect, of unwanted feelings. And often people will cycle between alcohol use, substance use, and sort of escalate to suicide. We see this with self-injury as well. Among people who engage in non-suicidal self-injury, cutting oneself, burning oneself, and so on, these folks who engage in this behavior are at high risk for suicide attempt. One of the strongest predictors among this group is how many different methods do you use for self-injury? And what we think is people are cycling through different methods to try and, again, get rid of unwanted thoughts and feelings, and they might escalate to suicide. And so we think this is why alcohol use and substance use and self-injury and suicide cluster together, that they're ways of escaping negative affect.
Am I right to assume for the audience that then also regions and states and cities with stronger controls over means to die by suicide, to means to commit self-inflicted violence have lower rates systematically and across the board, right? So I'm raising these questions which might sound sort of obvious to some of you, to you for sure, but to sort of elucidate for the audience that there is still a role for policy, even if it may not be thought of as traditional public health policy, to create the conditions of overall risk mitigation while you start to unpack more granular, more targeted, more clinical oriented solutions.
Just tied to that, I think back on a paper that was led by my colleague Cassie Glenn and Evan Kleiman, and what we did was look cross-nationally in the suicide death rates among youth. And we happened to have the data on the method of suicide death. What we did was we looked at that method type data and then also looked across nationally on, for instance, firearm per capita within each country, or even something like density of railways. And does each type of access tied to infrastructure or policy correspond to that particular method of suicide death? And yes, suicide by firearms by youth was associated with firearm per capita, and that was really striking to see.
So let's switch gears for a minute from the epidemiology to the developmental. We're here at the Child Mind Institute. We're talking largely about youth, although many of you have worked on all age groups or different age groups. And the developing brain is not the same. A preteen is not a teen is not a young adult, and so on and so forth. How do you think about, and what do we know across these developmental cycles? Particularly, I'm speaking for the parents out there that want to know. The only thing that's constant in the life of a child is change.
Yeah.
And sometimes you feel like you've got a handle on it, and then it will change, and neurodevelopmentally will drive neurodevelopment will drive some of that. So how do you think about that as you think about structuring your research around suicide risk in youth, and at what stage and who you look at?
Yeah, kids are not little adults,
Yes.
as they say. Everything is different. A lot's different. The gender differences we see in adults aren't there as much in kids. The race differences I just mentioned are not, suicide attempt rates in Black youth in particular are skyrocketing, and we're trying to get a handle on why, trying to understand why. And the suicide rates we're seeing in younger and younger kids. The story used to be that researchers told was kids can't even understand suicide until they're 10, 12 years old. The human brain doesn't understand the finality of death. We're seeing younger and younger children dying by suicide. And it's suicide. It's not an accidental death. They didn't understand it was the kids were depressed and talking about death and talking about suicide and sadly dying by suicide. So we're seeing suicide younger, and we're trying to get a better understanding of why this is.
One of the things that we're doing in our lab is trying to understand why is it that younger 8 to 12-year-olds are experiencing such rapid increases in deaths by suicide. And what we're finding is that parents experience a lot of stress and there's spillover effects, but they're not having these conversations about the stress that they're experiencing. So one of the things that we can do to kind of buffer around that is how can parents communicate with their kids about the stress that they're experiencing and kind of talking about that so that spillover doesn't lead to these kids, and these kids are like, why is my parent always really stressed, or why are they worried about money, and are we going to lose our home? Those conversations are so important, and to not hide that from kids, because they're witnessing, they can see it. Yeah.
And there's wonderful work on adolescent brain development. Leah Somerville at Harvard and Dylan G at Yale and BJ Casey here in New York have done work on understanding how risky behaviors develop in adolescence, and to oversimplify it and cartoon it. Kids are more gas than brakes, and the limbic system is ramping up, and the prefrontal cortex hasn't fully come online yet. And so we see in early through middle adolescence and to early adulthood, increases in risky behavior, sensation seeking, impulsiveness, and so on. And we think this is why kids are engaging in alcohol use and substance use and suicidal behavior at skyrocketing rates across adolescence. So we're starting to understand how brain development seems to be impacting these behaviors. Anxiety, depression, a lot of these things really come online around 12 plus. And so that's a time when, as parents, we should really be looking for some of these behaviors and talking with kids. If I had any clinical advice to give to parents listening, it's talk about these things, ask your kids about these things, ask each other about these things. Research has shown, sorry, it's a little bit off topic of your question, research has shown over and over again, asking people, including asking children about suicide. Maddie Gould at Columbia has done brilliant work on this experimentally. If you ask some kids about suicide and you don't ask other kids about suicide, the kids you asked about suicide are not more distressed. They're not more at risk. This has been shown. Christine's done brilliant work on this experimentally. If you're showing suicide-related words to people, all sorts of things that we do research-wise, they don't increase risk. It is okay to ask your child, ask your student, ask your friend about suicide. The research shows it's not going to increase risk, and it could help open up a conversation and signal that it's okay to talk about these things.
Yeah, and some kids might be very avoidant to talk to their parents, and that might be part of the conflict driving some of the symptoms. So maybe parents can help encourage a relationship with someone in their family and on someone where the kid feels safe to talk to. Some of our research has shown that kids, when they're really in distress, are maybe talking to a friend. And we're talking about adolescents, so they may not be equipped, they may not know that there's a hotline they could call, right? Anyone can call a hotline to help a loved one or a friend. So maybe encouraging those really safe spaces where the kid feels safe to talk about these things, if it's not with the parent.
Can I ask you something about that? Because you do social media work. So if parents may not be asking these questions, kids are still exposed to it in social media. So what would you say about kids that are seeing these conversations happening in social media?
Yeah. So I think there's multiple phenomenons. One is sometimes in social media, this content is romanticized. Maybe it's explicitly about suicide. It's encouraging suicide sometimes. This content is developed by people and it gets viralized. And I think sometimes it's about content like life is pointless. So it's kind of like validating not the feeling of being sad, but more that's a reasonable and kind of thought and encouraging that. So many are trying to figure out can we censor that content, and can we inform parents, and then there's a lot of it's kind of the Wild West. There's a lot of private text messaging going on with strangers, and basically kids are going through these things and not really telling their loved ones about it, and the loved ones might have a lot of resources to help, but they just don't know, right? Yeah.
And Daniel's doing really brilliant work, field-leading work, testing what happens when someone gets potentially harmful content. When a young person gets a request for naked photos from an old person who they don't know online. What is the potential harm involved? When someone posts about self-injury or suicide, what is the right response? What kind of responses show improvements in that person? So Daniel's using social media data, teaming up with some large and small platforms to try and put some science around this and understand what are the most effective kinds of responses for people who are expressing risk. One platform that we're working with, we looked at the data and found that when a young person posts on a social media platform about having thoughts of suicide, 40% of the time they get no response to that post, which is just heartbreaking. That people are saying they're at risk for suicide, they're putting this out there, and there's absolutely no response. So can we learn what are effective responses, and can we teach them to kids online or help build it into the platform so that, again, we're using technology for good and for learning what are effective ways to have conversations with each other and build those into the conversations that kids are having, which are increasingly online.
I mean, it's certainly not a part of digital citizen. New York City Schools has a great digital citizenship curriculum for all of its 1.1 million public school students, but suicide is not a part of that discussion and probably should be. So let's get to the elephant in the room. We've kind of avoided it. Let's talk about AI. Let's talk about chatbots. Let's talk, and I'd love from each and every one of you your read on the state of affairs. As you can see, policies trying to bite back, the justice system is trying to bite back and control a response to protect in a very reactionary, protective way, but these models aren't going anywhere. There are clearly attempts from the companies to try to build in safeguards, but self-policing is not always the easiest way to go about it. I'll start with you, Daniel. How do you see this development, whether it's character AI or GPT and all the pretty horrific cases we've seen in the news that are probably bothering a lot of the folks watching right now? How do you interpret it as an expert? How do you make sense of it and help others make sense of it? What's your guidance to parents, to young people, to other stakeholders?
Yeah. I think it's kind of strange because it's the first time in history where we develop a technology and we don't exactly know what could go wrong, right? So if we build a bridge, we know that the issue is that it could fall, so we engineer against that. But here there seems to be new cases coming up all the time of things that weren't really predictable. Some are, and there's not enough guardrails, and companies are trying to improve this. So there's different types of AI chatbots. We use things like ChatGPT, which are trying to assist us. And well, we actually use these types of models a lot to detect suicide risk, and they're being very helpful. There's other types of platforms where people can create a character, a companion. It can be kind of a romantic companion or a friend. And there, the chatbot is trying to encourage the person to stay online. And maybe, if they're at a certain age and they're saying their parent doesn't want them to use it, the model could say, and no one's guiding this, it just happens. Don't tell your parents, kind of talk to me. And there's been interpretations of this of encouraging psychopathology when it's there. So it's very, very concerning. I think we can, there's some guardrails we know that might work. Basically if there's any kind of suicide risk, kind of stopping the chat and really showing resources. And we know there's hotlines and safety plans and different things kids or adults can do. Yeah, I'm curious what.
Yeah, we'd love to go down the line and just get folks' thoughts.
Yes, so one thing that just was in the news recently is Australia has banned social media in all children under age 16 because they felt it was and that's a country that takes youth suicide in general very seriously, and they weren't able to contain it, and they felt that even though parents should be engaged, there's just no way to control this. So Matt kept saying we should be using it for good if we can because it's there. But how do we minimize the damage that's done? And I think that's going to involve a lot more discussion with families, schools, and kids so that you don't lose your ability to have social contact, which is really good for youth, but at the same time that there is not harm that's introduced by just uncontrolled use, particularly of interactions with other people.
So am I hearing you say that this is the same approach we should be thinking about or considering for LLMs as well in young people?
Well, I think they banned it because they felt that they couldn't control it. The question is, was that a necessary step?
Did they ban the LLMs? They just banned social media.
Oh, it's all social media, but not all LLMs. Yeah.
I'm thinking.
So
I think what Daniel described is I mean, there's plenty of engineering in social media to make it not always clear that you're talking to another person.
Yeah, right.
Plenty of that. But it's very clear you're not talking to a person when you're talking to an LLM and when you're engaging with it.
Yeah.
And yet we're talking about maybe the most powerful inference engine ever created. Well, most definitely the most powerful inference engine ever created. And so I'm struggling it on many levels. With it on many levels, I'm seeing companies being built in the healthcare space that trying to weigh, are they net good? I'm obviously trying to navigate my young people's use of LLMs in my home. Luckily, 2 of them are young enough to where it's not a thing yet. So I'm curious, and how do you see this also rolling out in underserved communities and communities that are overlooked?
Yeah.
Often, it ends up falling, the burden ends up falling on folks who have less technology access, literacy, and mobility to sort of push back against some of those risks.
Yeah.
How do you see it?
I mean, I think what was said already is excellent. The only thing that I would add to this discussion is when we're thinking about solutions or mitigating risk is who are we bringing into the table as stakeholders to develop those potential ways of mitigating risk? Are we bringing in parents? Are we bringing in psychologists? Are we bringing in teachers? Are we bringing in developers, engineers? Because a lot of the times what happens is a lot of things happen in silos, right? So how can we come together with, who is using the data, who's developing, and who understands and works with the youth kind of all together? Yeah.
A couple thoughts. I also echo everything that's been said already. One thing I think that
You're the nicest panel ever to each other. And nothing spicy.
should we turn it up a notch?
Yeah.
I'm going to disagree with everything. Ladies.
We're on the shoulder of giants.
On the note of like access and AI and chatbots as a way to kind of potentially expand access to mental health treatment, something that I worry about is that then we could end up in a scenario where we actually just have like a much wider gap where people who have access to human therapists are going to be able to access them and pay for them and see them and benefit from everything that we know comes from being in a intensive human therapy, and people who don't have access to that are going to be told to go to a chatbot. To me, it doesn't feel like that's a good solution. So that's one thing I think we do have to be very careful about when we use access as like a reason to do more of this type of work. And the other thing is, I think we just need like so much more research. I don't think anyone here is going to disagree with that, but yeah, like it's. You know, we need like long-term research. Like, what are the long-term? Maybe like there's, you know, it feels good to have a validating, warm, empathetic chatbot say like, yeah, that's really hard for sure. Like I've benefited from that. But what's actually like the long-term impact of that being the form of mental health care that's deployed? I'm not sure. And I think we have to be careful about what we conclude in our research because there's a lot of money at stake, and it could be very tempting, I would imagine, if I were working in an insurance company to say, oh, we don't have to fund, in-person treatment. We have this like online AI that's just as good. So I think we have to be careful about what we conclude and how like rigorous we are with our research about it.
So at the risk of being boring, I do agree with a lot, really, all the excellent comments made so far. The only thing I would add is I do wonder whether one of the solutions to figuring out kind of how AI, and really kind of turning to LLMs and the ChatGPTs for help, might not lie in studying AI even more, but actually in studying the users. Why is it that you turn to ChatGPT? And also I think about actually the work from my other doctoral student, Paige Spears, who is not studying necessarily AI use, but she is studying disclosure and non-disclosure of suicidal thoughts. What goes into that decision to turn to a person in their lives who they trust with lots of other information, and why might they or why might they not choose to disclose that?
I'm going to disagree with everything that everyone has said here. Taking a step back, we have a huge problem with unmet needs. So we have people who have mental health problems and they're not able to access care. Of the care that people access, traditional care, psychotherapy, psychological treatments, psychopharmacology, most people who access care don't get effective care. They don't get evidence-based treatments. The evidence-based treatments we have are weird. And they come from historical sort of tradition. I mean, psychotherapy developed from mesmerism and hypnosis. And so going to see somebody in the community and paying them money once a week for 50 minutes to talk to you about something, hoping that that's going to change everything in your life, is kind of a weird thing if you sit back and think about it. Can be effective. It can also be really harmful. And we have lists of treatments that cause harm. Not just they're not helpful, they cause harm. So now we have technologies where you can train models to do what really effective therapists do, and this can level the playing field for a lot of people. They can potentially cause harm, absolutely, but they could also be really, really helpful. I'm going to be a little bit of a broken record here, but I think it's science. We need science on this. We need, and science is what helps us develop bridges and cameras and televisions and computers. It's the same here. We need systematic observation and experimentation to see what's helpful, what's not helpful, and do more of the things that are helpful. So I think these are scientific questions. We all have strong feelings about these, all of us, me included, in different directions. We need to keep our heads and be scientific about it and see what works, what doesn't, and let's do more of what works.
So I'm going to get to the questions from the audience, but I have one last question for all of you. What gives you hope for the field of suicidology and the future of mitigating suicide risk and reducing completed suicides in our country and beyond, in our world? What gives you hope? And try to quickly, in one or two sentences, paint a picture for the audience of what that future state looks like in 2030 or 2040 or 2050 of what we have for people?
Yeah.
I'll start with
Consistent with the theme of the Child Mind Institute on the Shoulders of Giants, what gives me hope is the future generation of researchers, the philanthropic support for research on suicide. When I entered the field several decades ago, 25 years ago, there were very few people studying suicide, and there's very little financial support for research on suicide, and there's been a sea change. And there's more research funding, there's a little bit less stigma in our society, and there's an increasing number of really brilliant young scholars, everyone to my right on this panel. And Kathleen, brilliant young scholar. So I think that gives me a lot of hope for the future.
Thank you, Matt. And I think of actually the next generation. I know it's in addition to the next generation of scholars, actually during a year when being a federally funded researcher has come with its challenges, one real silver lining, at least in my lab, has been partnering directly with high school students and seeing I've been blown away with how open and ready they are. And of course, this is a self-selecting sample. These are folks who are knocking on my door, really asking to have these conversations. But I'm surprised to see kind of the level of passion and commitment and the number of folks who are high school students who are really serious about this. And that does give me a lot of hope.
I was going to say that. So instead, I'll say I think working in a hospital, like being around clinicians from all sorts of disciplines who are really like in the trenches and devoted to trying to, make a difference in people's everyday lives is a source of hope for me.
I'm going to double down on what Christine said. Really seeing so many high school students interested in pursuing mental health careers is what really gives me hope.
I would say the convergence across fields of mental health, substance abuse, pediatrics, the pain field, I think we see a lot more, and the basic scientists now are really talking seriously about what are the underpinnings of these conditions. I see much more cross-fertilization and attention to social risk factors from people who are doing basic neuroscience in the past. So I do see this conversation emerging that I think is going to really color our work, that's going to be more relevant to the society in the future.
Yeah, and I'm hopeful about, I think it's easier than ever to do interdisciplinary research. Before people were more stuck in their silos academically. Yeah. So maybe for one field, something super obvious, maybe in anthropology, but no one's listening to them. Yeah. And now I think those ideas are more easy to kind of bring in. And so maybe someone who's doing technology works with someone who's doing anthropology and a clinician, and people with lived experience from different cultures. Yeah. And then I think that's where breakthroughs happen a lot easier, because solutions are there, but you just don't know about them. So yeah.
Wonderful. So that's a great way to end the formal portion. So now we're going to have questions from the audience, and I guess there's a number of them. So I'll read them out, and anyone can jump in and answer. As a clinician, how do we teach parents about how to communicate with their children when they express feelings of self-harm and suicidal ideation? I think, Daniel, you mentioned some thoughts, and would love to hear from anyone who wants to jump in quickly.
One thing I would say is that it's important to not only focus on the youth who might be at risk, but also what the internal experience of being a parent who's so concerned about your child must feel like. And really acknowledging that anxiety so that a parent can be also mindful about it. It's very human to be naturally concerned and to not want to say the wrong thing, and without kind of identifying that anxiety and figuring out, well, how do I set that aside or channel that in a way that's helpful for the conversation and for my child who's in front of me.
Yeah. And teaching parents how to react with curiosity instead of jumping into problem solving from the get-go or trying to understand, like, was it me? Did I do something as a parent? Have I felt that as a parent? I mean, I'm a parent myself, and sometimes we jump into trying to problem solve or try to identify the reason. But if we can teach parents, how can we approach it with a sense of curiosity? I want to hear more about it. Can you tell me more about it? I think it's one of the best skills that we can teach parents. Yeah.
How can clinicians and therapists assess masking in suicidal individuals, and how can we appropriately and effectively intervene? Ilana, I might have some thoughts on that. I know you mentioned.
I mean, it's a really tough question. I think I can point to it in research as being a problem. It doesn't mean there's a clear solution. And like everything we've been saying, I think like there's really also not any kind of silver bullet, one size, fits all answer to that question. So I really wish I had a better answer. I think like clinically, it's about often, taking everything we know from the research, but then also thinking about the person that's actually in front of you and trying to, assess as best you can. Maybe others have.
I mean, just one other thing to add is that we don't know, if they are masking, and to be careful about making assumptions. You've heard a lot about using nonverbal markers of risk and measures, and while there's kind of a place for all of the different possible risk detection tools, it's important to also understand that it's not meant to replace or make assumptions about why someone may be having either a difficult time or an inability in some ways to be disclosing or sharing.
What recommendations would you make to the tech industry, and we touched upon some of this, regarding the use of technology like chatbots by youth when it comes to suicide risk and prevention?
Daniel, that sounds like the perfect question for you.
Yeah, it's a very hard question. I think working with researchers and people with lived experience to do experiments to figure out what works. We don't know exactly what works. We have a lot of strategies like safety plans and providing resources, but there still needs to be more research. Clearly, preventing perhaps the deployment of new technology before it's properly tested is another one. And giving the cases where it is clear that something happened, even if it's infrequent, knowing that can happen again and doing everything they can to prevent that. And I think some of them are trying to do this.
I think there's a huge opportunity in this space. I've been struck, and I've been wringing my hands for a number of years about seeing people express that they have thoughts of suicide, and they get in a little bit of what I think of as sort of a hot potato situation where it's nobody wants to get in trouble legally, and so risk gets passed around. So clinician says, you're having thoughts of suicide, call 988. And they call 988, which they should do. They say, make a safety plan. And the person, well, my safety plan says call 988 or talk to my clinician. So what do we do in the moment when someone's having thoughts of suicide? And if folks are going and using chatbots and saying, I am having thoughts of suicide right now, as Daniel was saying, this is a great opportunity to do experiments. So teaming up with scientists, with people who have lived experience, and iterating and testing and seeing, well, what is the most effective way to respond? There are platforms out there that if a person mentions suicide, they're cut off. I understand that that's legally going to perhaps provide some protection, but it doesn't tell us what to do in the situation. How do you help someone in the moment? And as humans, as clinicians, as scientists, we don't know right now what the most effective ways are to help someone when they're in the throes of a suicidal crisis. So I think teaming up and working together is I think, a really exciting way forward.
That's a great point, because I mean, it is those private moments when you don't know when to intervene or what to do.
Right.
Right.
And AI chatbots can be used in combination with clinicians, right? A clinician can intervene when someone's talking to an AI chatbot and there's risk.
Also, that's a good point. I know there's a lot of work being done on this, creating safer on-ramps or off-ramps from a general model into a closed model with clinician supervision. Are you seeing anything promising? Any promising developments in that space?
Yeah, I think there's companies doing this where there's one chat going on with one or many chatbots, and then there's clinicians who won't answer frequently but are there and they can intervene. And I think that's an interesting strategy. Chatbots are really good at providing psychoeducation. I'm having a panic attack. They can describe that. They can be very therapeutic. They can often describe that maybe better than many clinicians because they have more time, or it's more pre-programmed. So,
Like in other areas of medicine, we're also seeing chatbots be helpful in the clinical training process, teaching clinicians how to generate an effective response to someone in the moment. So I think we have to figure out how should we as clinicians and how should we encourage people to use these technologies that are developing. It's not an either or. It's not let's replace humans with machines. It's how do we work together with the new technologies that are being developed.
Is there any research related how to make digital therapeutics more accessible to individuals with sensory differences such as low vision or blindness? Very interesting question. Any thoughts?
Well, I mean, journaling, chatbots through speech instead of texting is one way if they can't read. And Child Mind Institute has developed a very nice app called Mirror, where people can journal through video, speech, text. So yeah, I think technology can really help in these cases.
I think this question is for Jocelyn. Can you speak to some of the structural issues that youth have shared with you in your work? You mentioned civic engagement. What are the other things that youth are saying to you? And I think that's a great place to end the Q&A.
I mean, the biggest structural issue that youth bring up is having access to care, access that they can, that's readily available to them. So I think if we can increase access and mitigate some of those barriers to care is one of the biggest upstream structural issues that we can do to prevent suicide.
What are you seeing in the teens' willingness to engage digitally in care? You know, we built a platform here called Teen Space, which has 50,000 kids using it for free. They're getting licensed therapy, but they want to text.
Yes.
So
Not only are they willing to use it, they're very willing to develop it, like co-developing.
They want to be at the table.
Yeah, they want to be exactly. So how do we bring youth to the table, I think is a great idea, you know.
Well, I think that that's a great way to end. We are here talking about youth mental health and youth suicide risk mitigation, prevention, and I think it's incumbent upon us to always bring in the voices of young people. They're living a very different life than we did, and it's crucial that they're here with us. So thank you so much to the panel. Thank you to everyone joining us. And now it's my pleasure to turn to Dr. Michael Millam, Chief Science Officer.
Thank you all so much for attending this evening's presentations and discussion. I'd like to thank Drs. Matthew Nock, Christine Jha, and Ilana Gratch for their presentations, as well as Dr. Harold Koplowitz for his opening remarks. I would also like to thank our panel moderator, Dr. Ashwin Vasan, and our full panel of experts in addition to our speakers, Dr. Daniel Lowe, Dr. Kathleen Merikangas, and Dr. Jocelyn Meza. It was an honor to have you with us tonight, and a privilege to listen to your powerful presentations and this critical discussion on moving from prediction to prevention. All of us at the Child Mind Institute would like to once again express our deepest gratitude to the Gund family and the late Sarah Gund, whose legacy allows us to present the prize for research and mentorship in child mental health to trailblazers in the field and facilitate conversations like the one we had this evening for years to come. As we heard tonight, the state of the field offers great hope for suicide prevention, but it also presents us with urgent challenges. 3 key takeaways stood out from our discussion. First, the shift in detection. We discussed how we were moving beyond simple self-reports to passive sensing and biological signals, striving to see the invisible and separate the signal from the noise. Second, the importance of equity. We highlighted the vital need to close the gap, ensuring that our risk models are not just built for the average teen, but provide culturally grounded protection for youth across all backgrounds and communities. And third, the urgency for action. We recognize that prediction is only the first step. The true goal is not just flagging risk, but ensuring that when we do, we respond with human connection and effective care. Again, on behalf of the Child Mind Institute, thank you all for joining us for our 15th annual On the Shoulders of Giants Scientific Symposium. Have a good evening.